everyone, my name is Lauren-Jane. I'm a junior doctor. I'm currently in F2. I really wanted to make a video talking about COVID-19 and my reflections on it, my experience of it, because it's such a unique situation that really we haven't seen in the world since the Spanish flu in 1918, 1919. And that was a really, really destructive epidemic. And actually we've not seen anything quite so horrific. We don't know how to deal with it as a world, really. And I think that's what we're seeing. And as a medic, you train to look after people when they're poorly, and that's potentially with infectious diseases. But actually, did any of us ever sort of really think about what it would be like to work in a pandemic? And I'm not sure we're properly trained at med school for this kind of experience, and we should be, because these things are not unusual. You know, 1919, 1918 is more than 100 years ago. I appreciate that. But that's not within, you know, a million miles. It's not beyond the scope of history. These things do happen. So at the start of the COVID outbreak, I was working in ED. If you follow me on Instagram, you'll know that I work in frailty at the moment. So what that basically means is that I work in ED, I have an office in ED, and I work for geriatrics, and I'm in the frailty team. So when older patients come in, we would assess them for whether they are a candidate for geriatrics. So age is just a number. If you are 90 but you live in your own home and you cook your own meals and you walk without a stick and you have, you know, largely good health, you probably aren't a candidate for geriatrics, actually, because you're not very frail. Whereas if you're 66 and you're bedbound and you live in a nursing home, you know, you might actually be a candidate. One of the things that frailty does is to try and, because frailty is such a destructive syndrome, we try and pick up on it earlier and make sure there's no delirium and things like that. And basically the nature of the job is such that we are screening and seeing a lot of patients in ED. So that's where I was working as an F2 at the start of the COVID outbreak. Now what this means is that we have a really global view over ED and also have the time to be able to look into kind of all of the patients that are coming through ED. And when those first COVID patients started to come through ED, I think that was a really unnerving time for those of us that were sort of seeing that, because the thing is, we don't know anything about COVID-19. You know, I'd never treated it. Your consultant has never treated it. We've never seen it. And as a doctor, that's very, very unnerving because you just don't know. So we started off by sort of looking into patients and trying to pick up those early sort of trends, what the kind of things that we could necessarily recognise for patients that were coming in, because obviously this knowledge is so crucial. And at that point, there were just no guidelines as to the more detailed way that COVID-19 might present. So, you know, things like the lymphocytopenia and all of those things, which it just wasn't out, that information just wasn't out there. And that was really scary. So we looked into that and tried to educate ourselves and arm ourselves with you know, what this virus did and what it does. What was really interesting actually about COVID-19, which became apparent later on, was that obviously in the flu epidemic, you know, kind of just January to the early March period, ED would be full, you know, with older people that are having, you know, lots of flu and very unwell chest infections over the cold period here in the UK. But many of those patients, they would come in poorly enough to be admitted. So really, really rubbishy chest x-rays, lots of consolidation, but their news scores, which is this is how we measure kind of how unwell people are. Their news scores wouldn't be terrible. So they might be a 3 or a 4. You'd see something that was a bit deranged. You'd have white cells that were deranged, and the patient would not look very well. You'd usually have something like they're a bit dehydrated or something as well. So the thing would be that they would always be worthy of coming into hospital and having treatment, but you wouldn't look at them and think, wow, that person is really poorly. And we would have hundreds of these in ED. And they would have similar, you know, 3 or 4 news scores. With COVID-19, what we were seeing was that many of the patients that came in were very unwell. So they had news scores of more like 6, 7, 8, 9. And that's very different to the flu, and very concerning, because the people that are coming in are suddenly coming in much more unwell than the people that had the flu. And that means that, you've almost got less time to get on top of that illness before it gets worse and worse and worse. You've got less of a head start with it, which again, because we don't know much about COVID-19 at that point, was very, very unnerving. Towards the start of COVID-19, when it became apparent that it was going to become a pandemic and when it was going to spread in the UK, we started cancelling all of our elective surgeries, elective, sort of outpatient stuff, and trying to clear the wards of anyone who really didn't need to be there. So obviously, because there's no elective surgery, the surgical wards were clearing out and things like that. And that means that to begin with, the hospitals were actually quite empty. It was quite eerie, because usually you would have wards that were teeming with people, ED teeming with people, and then all of a sudden the hospital is quite bare and quite empty, and you're walking around almost waiting for this coronavirus to hit. And it was a really awful feeling, because you know that there are people out there who are going to be in that bed in 2-3 weeks that just are kind of walking around, probably relatively fit and well, enjoying their lives. And that was not a nice feeling either, just to see all those empty beds and just to be waiting, really. It was just, in that intermediate phase, it was just this sense of anticipation, and like I said before, the not knowing, the anticipation, just not knowing when it's going to hit, what it's going to be like, how bad it's going to be. We didn't know what measures the government was going to put in either. So I think, to summarise, up until this point, as a junior doctor, we were just sort of floating around, not really knowing what was coming, what we were going to be dealing with, how it would affect us. I'm pregnant. I'm 33 weeks at filming this. So there was also, for me, there was that sort of anticipation of how it was going to affect me so late in my pregnancy. At this point, in addition to working in ED, I was also doing clinics in the community, and I was working in a community hospital. It's a rehab facility which looks after lots of older people who are not poorly enough to be in hospital, but also not well enough to go home. So my level of exposure, especially being in ED, was quite high. The thing that happened next, probably that's most significant, was that all of the rotas were being planned to be changed. So whereas usually we have like a TNO rota, and if you're a TNO doctor, you'll be on TNO, and if you're a diabetes doctor, you might be on the general medical rota, but you're basically on diabetes, or if you're on peds or whatever. All of those rotas have been sort of redesigned so that we've got a huge pool of medical doctors, because obviously, some estimates are saying that 1 in 4 doctors are in lockdown, off sick. So we need to be able to cover those vacancies, and it just makes sense to be able to pull from different specialities, especially because of the closure of elective procedures. Some of those specialities are quieter. Some specialities were protected, so trauma specialities, obviously things like paediatrics, obs and gynae, they still need to function as they did, so they wouldn't be joining any kind of rota. And the other thing that happened was that we didn't rotate. So usually we rotate 3 times a year, so in August, in December, and in April. So just before our coronavirus hit, just before we were about to rotate in April. Now this rotation is always a bit of a nightmare for everyone. It's great. Rotating is great for our education, but at the same time, it causes a lot of upheaval, because one day you're an obs and gynae doctor and the next day you're an ENT doctor, and the two don't really meet. So it takes you a couple of days to have your induction. It takes you a couple of weeks to sort of really get to grips with who's who and what's what and what equipment you use and all of that stuff. And it's a time of massive upheaval. So actually rotating at what was, the beginning of this epidemic was not necessarily the best thing that could be done. So actually in my trust, we stopped that. So everyone was staying in the rotation that they'd been in before, unless they'd been on a community rotation or an academic programme, in which case you would stay where you'd been. In which case you would be moved into ED or something more acute. About a week ago, a couple of weeks ago, the national guidance for pregnant women changed, and I had to start screening patients remotely. So I felt like I was still contributing, because what I would do is I would screen patients remotely, and just make sure that anyone who'd been tagged to geriatrics definitely didn't have any symptoms of COVID, because obviously at that point we had full bays of patients that didn't have COVID-19, and the last thing we would want is a COVID-19 patient who's early on in their pregnancy to go up there and spread the virus to what is a very vulnerable pool of people. So that felt like really valuable work to be doing. Fortunately, the RCOG guidance changed about a week ago, and they said that pregnant women of my gestation, so that's more than 28 weeks, pregnant healthcare workers aren't allowed to work anymore in the hospital, so I had to be sent home. So I am at home now, and that comes with an excessive amount of feelings of guilt, really. I think as a doctor, you train to be a doctor because you want to help people. And I think often, and I think I've said this in previous videos, as a foundation doctor, you often feel like you're not really helping people. You're doing, you know, the admin, you're doing, you know, all the stuff that needs to be doing, and it is helping people, but it's not, you know, getting in there and really, really making a difference, the kind of difference that you imagined when you're at med school. That comes later. You have to learn first. And this is an opportunity to really, you know, get in there and help people and make a difference to people's lives. And not being able to be part of that is hard. And I think when you hear that, you know, healthcare professionals becoming unwell, when people they're becoming very unwell, and they're doing that because they're healthcare professionals, they're putting themselves at risk, and you're sitting at home and being the one that's not at risk, that's also very hard to deal with, because I want to support my colleagues, and if they're there, I want to be there. I don't want anyone else to be having to fight a fight and work extra hours because they're covering my shifts, when I have this knowledge that I can share. I understand the logic behind why I'm here, why I'm benched, but it has been hard actually to step away when you just want to get there and you want to support your colleagues and you want to make a difference to patients. And really, you know, this virus is terrifying people. It's brought our world to a halt, and to be a part of, you know, kicking it in the bum, you know, that's something to be really proud of. And, you know, all of the healthcare professionals that are out there doing that are just amazing, and you're really being part of history, I think. And a massive thank you to everyone who is doing that. And that goes not just for, you know, doctors and nurses and paramedics and people like that, because everyone, I have to say, as a doctor, people are very appreciative of the work you do. But there are so many professions in the hospital that just don't get that. When I was in the mess last week, I saw a cleaner. She was cleaning the mess kitchen, and I got speaking to her from a safe distance of more than 2 meters away. And I said to her, "Thank you so much for the work that you're doing. It's really appreciative," because she's there. She's in the hospital. She is alongside all of the doctors who are, you know, potentially infected. And she just looked so taken aback. And she was like, "Well, thank you so much for saying that. We don't necessarily value their contribution. We're actually there on the front line as much as everyone else is. And there are people like cleaners and porters and admin staff and people who are still in the hospital that are not necessarily getting recognised as key workers. People like, you know, lorry drivers and dustbin collectors. You know, HCAs never get mentioned. There are so many people who are out there that are really helping towards kicking the bum of COVID-19 that actually we're not recognising, and I think that really needs to change. And I'd really like to do something about making sure that people like that wonderful cleaner who are going to work day in, day out, really get recognised for their contribution. So obviously I'm in lockdown now, so I have no further insights to offer at the moment on COVID-19 in the hospital. That's where my experience of it as a doctor sort of ends. If you have any questions about things like how it's affecting my training, you're always welcome to message me either on here, or I am at the Surgical Doctor on Instagram. Please stay safe, take care of yourself. Thank you for listening.